showing through? Okay. All right. So very introductory considerations. For substance use disorders, using the criteria in the DSM for youth. And really the question is, does the DSM provide a developmentally suited metric for considering diagnosing for adolescents? And we're going to start out by considering who are adolescents, who are we thinking about with this? I wouldn't be surprised if all of you have heard this analogy before that the period of adolescence is comparable to a fast car with bad brakes or a race car with bad brakes or whatever the analogy is. With the thinking that puberty and that period of life really turbocharges a large engine and the accelerator, and then the inefficient cortical areas, and especially the inhibitory prefrontal cortical areas, um, operating less efficiently as the brakes, they don't work as well. So there's a big rush towards things with a lower chance of being able to slow down in time, kind of thing. It's a useful analogy. Uh, there's certainly uh, there's certainly a lot of comparative truths to that, but I don't think that it really captures the essence of what's going on in adolescence. And it is, in one way, it's useful, but in another way, that it's kind of unfair. Um, the adolescent tendency to approach novel situations, to seek out new experiences, to take what we on the adult side would consider increased risks, it's typically compared to adults, sometimes to children. They've got a foot in both camps, right? So they get these comparisons, but neither of these comparisons are fair because it doesn't really capture what's going on in adolescence, and it doesn't necessarily recognize, and you can take necessarily out of that, it doesn't recognize that adolescence is a very unique and purposeful period of life that is not comparable to the one that came before or the one that is being evolved into. Rather, it's a unique period of life. So while this analogy has some utility, it also has some dangers in that it overemphasizes the risk view, highlights that risk view for adolescents, and ignores some of those other relevant areas. So it's one that sometimes I use, but in a cautionary way. You know, when you create slides in a didactic, in a training to generate a discussion, the general thinking is you have a couple of talking points and avoid including a ton of text. Uh, I couldn't distill this down, and I really like this report. It's 7 years old at this point. I think it came out in 2019. It was like right before the pandemic. Um, from the National Academies. It's the promise of adolescence, realizing opportunity for all youth. It's the single best distilled resource that covers this period of life that I've encountered. It is all about this period of life without considerations of, oh, they're young adults or they're big kids. It's very specific to this period of life is unique and it needs to be considered that way. And a couple of things that came out of this, and this was from the opening summary of this document that you can download for free if you are linked with National Academy of Science, Engineering, and Medicine. If you're linked with them, you can download it for free. You can get linked with them for free um, and download it. And there's a lot of other supplemental areas if you're not familiar with NASEM, um, with things that you can find. But this one in particular, when it comes to adolescence, has been very useful. Um, it points out that neurobiologically, throughout adolescence, the connections within and between brain regions become stronger and more efficient. That's pretty, I don't want to common knowledge, it maybe isn't quite right, but in this group, it probably is. Unused connections are pruned away. So the adolescent brain it might be working less efficiently than compared to adulthood, but it has so much more opportunity for options. There's more connections that are going to be needed, and so it's by practicing different things that the ultimate pathways start getting pruned away, and it's that practice and those extra opportunities. So it's less efficient, but there's more opportunity. Such developmental plasticity, that opportunity, means adolescent brains are adaptive. They become more specialized in response to environmental demands. The timing and location of these dynamic changes are important. The onset of puberty brings about the start of these changes in the limbic system. Um, and the limbic system, among other things, has to do with approach, avoidance, reinforcement, that sort of thing. So it starts in that increasing sensitivity to rewards, which is meaningful, especially when we're talking about psychoactive substances. Also has to do with approach towards things that could be threatening, that are novel, which is very important, and in connection with peers. In contrast, the areas that will put the brakes on, that more inhibitory control, the more the risk weighing kind of decisions, those executive management kinds of things in the cortical regions are slower to rapidly develop, like it happens at the start of puberty. So that cognitive control, that self-regulation takes longer to develop, but there's good reasons for that longer to develop because there's a lot of room for practice during that period of life. So consequently, adolescent brains are not advanced child brains or immature adult brains. Kids. I say that about adolescents and it gets confusing. Adolescents, they're neither kids, they're neither little kids, nor are they adults. And it's not fair to make comparisons either direction. What I really like about the way that it was addressed in this guide, they talk about the purposefulness of this period of life and that evolutionarily, this is where they're supposed to be, and they are supposed to be approach things at a greater rate than being inhibited to do that. Seek out novel things. There's really good purposes behind that. So the temporal discrepancy and the specialization, these connections, makes this period of life unique, but it also makes it very purpose-driven. The developmental changes heighten sensitivity to rewards and willingness to take risks so that they go out and they find new things. The salience of social status, propensities that are, all these things are necessary for exploring new environments so that they start to move out beyond just the immediate family so that they can start making their own path, so to speak. I was thinking about this earlier, and I'm wondering if things would stay the same that we often think about them, like right now, is that going to would that have the possibility of impacting further evolution? Because we think about now, kids are staying home longer than they ever have. They'll return home. Is that going to increase if that stays the same? Likely, this is a blip, but if that stayed the same, would that increase the length of adolescence? That willingness to seek out new experiences and the importance of people outside of the immediate family. Um, you know, Evolutionarily, was that expanded even more? The guide doesn't talk about that. I was wondering about that. So who are we talking about with adolescence? There's a mention already that yeah, it starts with the initiation of puberty, which happens really before you start to see the external signs of it. Coming from the Cleveland Clinic, kind of a generic, I don't mean that in a critical way towards the Cleveland Clinic, but kind of a generic definition that I think a lot of us have in mind one way or another, that it's the period of transition between childhood and adulthood. That kind of diminishes the importance of it, it seems, though, if we say that it's the transition period. It's like um, Freud's latency period, right? He was really specific about some of those developmental things. Then there's the latency period where nothing happens, and then you're an adult. Um, it might diminish the importance of what's happening during that period. children who are entering adolescence are going through many changes. Rocket science, right? Adolescence begins at puberty, which now occurs, and this is significant, which now occurs at an earlier age on average than it has in the past. The end of adolescence is tied to social and emotional factors that can be somewhat ambiguous. And so the starting point and the ending point are both kind of ambiguous. From the World Health Organization, which considers things just a little bit differently, adolescence is identified as a period of life with specific health and developmental needs and rights. Also, a time to develop knowledge and skills, learn, manage emotions, relationships, acquire attributes and abilities that will help youth move into their adulthood. So now the part that I always hate in any kind of didactic or training, it is prompted participation. Before we move on with any kind of suggestions in where those boundaries may lie, what do you folks think about what are the boundaries that identify the period that we would be considering for adolescence? You can put it in the chat, you can unmute.
I have a question about the definitions that you describe here regarding culture. So, for example, there are other cultures where all these descriptions about adolescence may not fit in terms of behavior. Uh, Example, India, the largest, what is it, population state in the world today, they have surpassed China, as we know.
Mhm.
And we look at adolescents in India, I doubt that their behaviors would fit these descriptions coming from what you have cited here. But even in the United States, there are other cultures. For example, in Utah, there is quite a large number of people whose behavior in their adolescence does not fit what is described here. And I wonder, how does their brain work? Do they have better breaks? Does their prefrontal part of the brain develop sooner? And so on. So I wonder if you could comment on that question. There are other cultures. For example, there's the culture of very ultra Orthodox Jewish community in Brooklyn, as an example, New York.
Mhm.
There are adolescents there too, but their behaviors as not doesn't fit these definitions that you describe here. So I wonder if you could comment on that.
So do the cultural boundaries, if I can paraphrase this and tell me if I have this correctly, um, do the cultural boundaries then impact the timing of the neurological development that was briefly covered here? Is that oversimplifying?
Yeah, that's one aspect of it. The other aspect of it is when you speak to adolescents in those groups,
Hmm.
they their what behaviors, their actions in day-to-day living do not fit what is described in maybe the majority of non-affiliated, if you wish, uh, American, adolescents that you describe. And so, what is happening here? Do they have different brains? Like what? How is that their behaviors are so different in adolescence?
Yeah,
Less,
so is it
significantly less impulsive to what we see in the general population.
yeah, so is it the external influence? Is it some sort of inherited genetic influence? Is it a combination of those two? I have not seen any studies taking a look at that type of exogenous versus endogenous influence. And I would open that up to anybody. Does anybody have any knowledge or recognition of that type of influence research? I'm guessing that folks are Googling that type of research right now, and that explains the absolute crickets.
Well, I'll just make a one quick comment.
Uh-huh.
There's a group of both kids and also specifically adolescents who have a condition that's been called ADD, ADHD, attention deficit disorder. And their behavior is very sensitive to external structures. In other words, if you give them attention one to one in a structured environment, their behavior, their symptoms of their ADD almost disappear.
Yeah.
Only in an unstructured environment is where their issues, symptomatology issues become most extreme. But in structured environment, their behavior changes. So their brain responds differently depending where they are. Is it a structured environment or non-structured environment? So I'm just using that as an example, and I wonder whether we see the same thing in adolescence.
Not just the different structure, but I think also cultural definitions of. I similar to that in thinking about the potential cultural influence on, and maybe it's not so much the cultural impact on the course of the development itself, but it is the cultural definitions of what's going on. I had the opportunity to work with several home-based teams in northwestern Montana, which is not really that far away in terms of culture. But after several years of providing very similar services to we do in Ohio, if you're familiar with IHBT, intensive home-based treatment, really with a specialization for co-occurring drug involvement, taking a look at who was being served and how they were described on the other side in a comparison of several years. In Ohio and some other programs that are more Eastern, a very high percentage of youth were identified as having ADHD as part of what was going on. And in the Montana teams, it wasn't a single, but in the Montana teams, ADHD was almost never identified. Descriptively, they were the exact same youth. Culturally, the explanations, and especially diagnostically, were very different. And so that cultural influence really stood out at that point. And so I don't know if that was having a developmental impact moving forward, if it was a cultural description impact, but certainly that is a big area of influence. And I'm interested to know if there's a more rapid move towards final maturation with the brains of youth who are in different types of cultures than the ones that were being considered here. And I don't know. And from the sounds of it, nobody has seen that kind of specific research. From the sounds of it from our small group, is what I'm saying.
Thank you for your comments. I appreciate it.
Yeah, my non-helpful, non-answering comments that kind of sidestepped, yeah, I'll give those at any point.
We do have a link in the chat, some cross-cultural patterns in adolescence from some ethnic and cultural studies. So we did have people Googling um,
Okay.
while you were, well, during the silence, people are engaged in listening and looking it up. So, um, oh, Pedro, if you want to unmute and talk, please feel free. Otherwise, people could check it out after.
But short of that, let's return to and the cultural impact can be a big part of this decision making. I guess in general, in your current practice, where are the boundaries of adolescence? And there's probably not an official answer to that, even for you individually. But what do you consider to be, oh, this is definitely an adolescent?
So I think like the boundaries around teenager, I guess, like that 13 to 18, whatever that social or cultural definition is one of the boundaries. I think the legal context of you're an adult when you're 18, or you can drink when you're 21, that kind of piece. I also think about puberty, and the biological pieces that are associated with brain and body. Those are some of the things I think of when I think about boundaries.
Yeah, thanks, Ashley. And I think a lot of folks use that 13 to 18 boundary for adolescence.
Now, it might be because of the age of my kids, but I definitely have started considering adolescence continuing into the early 20s, much more than I ever did, when they were younger. But um,
Yeah.
and to think about the fact that yes, you can join the military at 18, you could drink at 21, but you're not allowed to rent a car until you're like 25. I think maybe 25 is when it ends.
I think if you want the real answers in life, ask insurance actuaries. Dina, did you have input?
Oh, yeah, Michael, thank you. I was just going to mention I more of a question of, of transitional youth and the readiness for adulthood. I kind of, yeah, exactly what Jackie just said, like, um, kind of their independence. Like, there's this TRAQ form that I've been trying to just gradually do with patients as they're reaching the age of 18, just like starting that discussion of like readiness to manage medication. I mean, there's a lot to manage on their own, and I guess outside of just the age range, because I see kids who are like up to 25, really. And I call them maybe that's the upper boundary, and it's difficult depending on their um, different pathologies and things like that. And so it's a complicated process, but I don't know if you could touch on that. Like, how do you determine when, um, obviously it's each individual case, but, um, just like gradually having these conversations with them and then involving the parent.
Mhm.
Yeah.
Yeah, and one of the pieces that you mentioned that really becomes an overlapping influence that we'll touch on is the what are the other existing pathologies? Or it doesn't have to be other, but what are the pathologies? What are the areas of need that are influencing the course of the development, the independent decision-making ability, and that sort of thing? So we're just going to touch on that. But that is a big area of consideration. So Jacqueline put in the chat, biologically, puberty has started, so that would be the start of it. Psychologically, as they move into greater independence, maybe that would be the end of it. There's no good, clear answers, and there is no singular definition. This is taken from a lot of different sources. One was that NASAM publication. Some of it comes from the CDC um, screening comments. The WHO has input on this. There's a lot of overlapping areas that encompass the area that a lot of times we consider with adolescence. A lot of times the term teenager is used that um, that assumes adolescence. Adolescence is probably a little bit bigger than that, but it does depend on your working definition as you're providing services to others. Child from birth to 18. That's typically the accepted definition for that. Nothing magically happens at 18, unless you're providing services to very angry teenagers who think that at 18 everything is going to be different. Um, Another even less defined and recognized term, and it's one that I use more than the others, and that's youth. Generally, that assumes that it's a little bit older adolescent, starting at about 15, but then going through 25, capturing that area that we consider to be transition age, and that's included in there. Transition age can be 15 through 25, it can be 18 through 25, it can be more open-ended than 25. Adult, legally anyway, starting at 18. Um, You can't buy alcohol or nicotine products until you're 21. So maybe it doesn't really start until 21. You know, there's those overlapping areas of consideration there as well. The definition here and the working definition for the consideration today, and this is being adapted mostly from that promise, the promise of adolescence, that it starts with the onset of puberty, which starts before a year and a half or so, before you see any of the outward signs of the initiation of puberty, and goes through at least about the age of 25. That's bigger than I think that we usually use when we're saying adolescence. But the operating definition here, especially as it comes to considering yes or no to any kind of substance use disorder, if you work with kids that have substance use involvement and you've done it for more than a year, you've probably seen kids who initiated substance use in the single digits. Maybe not to the level that we would say that this has risen to interfere. Well, I don't think you could say any level of use would be, you know, not interfering with functioning, but that we would consider to the diagnostic level. But you know, the earlier the use is initiated, the more problems that it predicts. So it can start very young. Adolescents and young adults are the groups that are most likely to use illicit substances. It's less so for the classic definition of adolescence, which really isn't captured here, but that would stop at about age 18. More of the definition that Ashley presented. You know, 13 to 18, 14 to 18 in that range. So from the classic definition, on the younger side, there's the initiation of use, experimental use, very bingy, opportunistic use. But the greatest amount of use certainly occurs during the transition age, young adulthood. If you want to find somebody who is using drugs, alcohol, substances in abundance and making very risky decisions and doing risky things at the top of the pyramid of those considerations, young adults are almost always at the top of those prevalence pyramids. So whenever it's initiated, the earlier it's initiated, the steeper the climb in this. But psychoactive substance use frequently increases steadily from about age 12. Certainly there's experiences of recognizing kids who started younger than that. But some sort of introductory initiation often, and this is in general U.S. culture based on prevalence reports from Monitoring the Future and National Substance Use um, NSDUH data. Starts at about age 12, peaks in young adulthood. This period of introduction to increasing initiation of psychoactive substance use coincides with a significant neurosocial developmental period where those inhibitory controls are being learned. Youth with substance use involvement, we know this is correlational. You probably say it's a little bit causational, but it's more correlational. Youth with substance use involvements have increased school problems, increased justice and police contact, increased risky sexual behaviors, STIs, also increased difficulties with co-occurring mental health needs. This is not to say that substance use is the cause of these things. If nothing else changed for youth with these multiple areas of need, these multiple areas of identified need, if nothing else changed and you just removed the substance use, the likelihood of these other areas being problems would stay pretty high. If you could just magically remove substance use, it would certainly decrease the impact. So there's a little bit causational, but it is more correlational than anything. That speaks to the importance of regular screening and identification, and then comprehensive integrated care because just treating one small segment of anybody, but my focus is especially with youth, just treating one small segment of it is not likely to make any significant changes. Of adults living with a substance use disorder, more than 90% of that started when they were in adolescence, when they were young. Overlapping all of this, and this is kind of getting to Dina what you were saying with that overlap. Half of all lifetime experiences, and that's not just the initiation, that's lifetime experiences of mental illness begins by the age of 14 and 75% before the transition age is done. So if those kinds of needs are overlapped with what's going on developmentally, and then substance use is thrown into that mix as well, that can certainly have very negative influence and potential outcomes. Identifying, being able to recognize substance use involvement, the earlier we do it, the better, because then the more opportunity that we have to ameliorate and slightly alter the course of this moving forward. A trick question. What is the most commonly used psychoactive substance by adolescents? Somebody unmute and throw it out, and then, okay, Ashley got it. Ashley, nice.
I'm just gonna
Um,
say sugar.
it was, they don't, because sugar provides calories, it doesn't count, I think. I think that that's how that's measured. But the most commonly used psychoactive substance is caffeine. Now, the most commonly used recreational psychoactive substance, Dina, is alcohol. I think a lot of people just guess that it's probably marijuana because that's what you hear about the most. But in terms of the ones that we're talking about, which would be excluding caffeine. So if you're used to the DSM, the other nine categories, the other nine classes that are identified, alcohol far and away is the most used. It's identified a little bit less by the youth themselves, by families, and I think by a lot of professionals. But it is percentage-wise not quite double that of cannabis on a regular schedule, but it is significantly more. When we're thinking about applying diagnostic criteria to youth, that's, there's a, well, you may not know if you're not really familiar with that one chapter in the whole DSM. There's 11 criteria to consider in a diagnosis of substance use disorder. This would be true applying this to anybody, but really applying this to adolescents. There's a spectrum of consideration. We can consider being very aggressive in our endorsement of criteria with youth, with adolescents. If we're very aggressive in it, that is, we're a lot more willing to endorse criteria. This gives us the opportunity to capture a lot more treatable cases and to track them, to identify them early, potentially heading off and reducing problems in the future. That aggressive approach can increase parental caregiver awareness. It has the potential of increasing defensiveness in the youth themselves, and it has the potential to be stigmatizing. Not just in terms of, oh, I have a substance use disorder, but as other people around that youth hear, oh, the kid, nobody would say is living with cannabis use disorder. The kid's addicted to pot. But that kind of label, that has really negative chronic, no pun intended with chronic, really negative chronic implications, some hopelessness associated with that. If you go to the other end of the spectrum, and certainly there's lots of room in between that, but the other end of the spectrum, if you're very cautious in endorsing criteria, this can reduce exposure to unnecessary levels of treatment involvement. When I started working with adolescents with substance use involvements about a quarter century ago, um, which sounds like there's a lot more gravitas associated with that, right? Just a long time ago. Any kid that provided a positive urine screen, and nobody said that, any kid that dropped dirty for weed, when they had some kind of external control, they were automatically sent off to residential treatment. It's driving an attack with a sledgehammer kind of approach. It doesn't have good outcomes. So the more cautious can reduce that. There's negative aspects to that as well. With that higher level of care than is necessary, you can think about iatrogenic impact on that. That is, as the treatment causes the problem itself. Or if it doesn't actually cause it, it can certainly exacerbate it. But on the other side of things, it can miss opportunities for early interventions that can, head things off. So in thinking about where you fall on this spectrum, if you're providing these types of services, and part of that is diagnosis to young folks, you can think about where you are on that spectrum. Part of the things that can lead into this decision making when it comes to considering the criteria, how much weight do you give to what the kid says themselves? How is that balanced then with the parent or caregiver's interpretation, with your expectations, with the reports that you get from others involved in the life of that kid? Teachers, child welfare caseworkers, judges, POs. Where does that weight go? And interpreting the individual criteria, what does the kid say about, have you ever used more than you intended to? The kid's like, no, I never used more than I intended to. If it's there, I'm going to use it, and thank God for it. But the parent says, oh no, they're always using more than they intend to. Where does that weight go? Where is that consideration? How does that come out? There's no definitive answers to these, but they are things to think about as you're considering these areas. The DSM in the introduction to this chapter, this substance use chapter, the addiction chapter, notes that a common factor for all the different types of psychoactive substances, there's 10 classes that are considered. There's way more than 10 in that, but 10 classes. All of them have in common that they activate the reward system. Caffeine would be on that list. It activates the reward system. When a behavior is reinforced, it is more likely to be repeated. Well, thank you, Dr. Skinner. Yeah, I mean, that's not controversial. Actually, none of this is controversial, but how much of it applies directly to adolescents? That piece applies to everybody. It goes on to say, furthermore, individuals with lower levels of self-control may be more susceptible. Well, what do lower levels of self-control mean to adolescents when we think about that period of life being defined purposely by quote unquote lower levels of self-control? How does that impact the diagnostic consideration? It makes sense when you're considering fully matured adults who probably can have lower levels of self-control based upon psychoactive substance use exposure during their early years. But how does that apply to adolescents? And how does that impact then the consideration of the different areas of criteria, or the different criteria in themselves? When thinking about a substance use disorder, it's described in the DSM as a cluster of cognitive, behavioral, physiological symptoms indicating the individual continues using the substance despite significant substance-related problems. There are different perspectives on that often, not always, often coming from the youth's perspective and coming from everybody around the youth. I don't have any problems with using. You've got problems with my using. I do not. What does that mean? That's also not uncommon to hear with a lot of adults, but it's a lot more expected with adolescents. An important characteristic of substance use disorders and an underlying change in brain circuits. Well, that's actively going on in adolescence anyway. all of these things complicate. Don't make it impossible, but they really do emphasize the importance of adapting the interpretation of these criteria to a lens that considers adolescence very specifically. These were developed for understanding adults. They were not developed for adolescents. So there's 11 criteria, 2 to 3 endorsed, mild substance use, 4 to 5 moderate, 6 or more severe. If you haven't looked at that chapter in a while since the DSM-4, they used to have substance abuse or substance dependence disorder, but now it's on this continuum. Another area of consideration, and I'm moving through, and I apologize, Nicole, that I'm taking forever on this, but um, I think that this is even more impactful when it comes to considering the specifiers within substance use identification. Do the period of months that are outlined in the DSM mean the same for adolescents as they do for adults? Does 9 months of abstinence for an adolescent still warrant an active diagnosis but an early remission for an adolescent? 9 months for a 14-year-old is forever. Does that mean the same thing to a 14-year-old as it does to a 34-year-old? At my age, 9 months was yesterday. But for a teenager, 9 months is an enormous amount of time. That's almost an entire school year. And if you're abstinent for that period, can we say that the change is ingrained? That it doesn't even need to be considered anymore because it's been adapted? If the kid starts to use again, it's not a relapse. It's a new behavior. That would be on the very cautious end of that spectrum, not on the aggressive end. The criteria are organized by areas of similar consideration. 1 through 4 consider impaired control. What does that mean for an adolescent? Social impairment, that's really difficult to consider with adolescents. Risky use, that's easier to identify from the outside, but not necessarily from the kid's perspective. And then pharmacological considerations, physiological, which are impactful for youth less than they are for adults. That's tolerance and withdrawal. Tolerance is there sometimes, well, often, especially with cannabis, less so with alcohol because theirs is more bingy. And withdrawal is even far less of an identifier. So consider that spectrum when you're thinking about how you approach helping youth and their families identify diagnostic, not diagnostic. But either way, if you go the very cautious route, that doesn't mean that we can't link them with services. On the other end of that, if your approach is on the very aggressive, I want to make sure that this is identified so that something can be done about it. It doesn't mean that we have to place them in a higher level of care than is necessary. So